Welcome back. In this last section, talking about the VITAL trial and talking about the implementation of a randomized trial, I want to talk for just a few minutes about the issue of blood collection. If we go back to our diagram about the trial, our 20,000 men and women randomized to getting either vitamin D or vitamin D placebo, then randomized again to getting fish oil or fish oil placebo. If you look down at the very bottom, there were a few more points that were said. One, that the study was going to be 5 years. One, that the outcomes were going to be cancer and cardiovascular disease. But then there's a point right here that's called blood collection. And that the intention of the design of the study is that at least 16,000 of the 20,000 people in our trial would have a blood sample that they would provide us as part of the trial. And that 2,000 of those people who gave us the baseline blood sample would give us a follow-up blood sample at 2 years and at 4 years. So I want to talk for just a second about why is it important? Why would we want to build into a study the collection of blood? And the reason to raise it is because certainly blood collection is something that people are not as comfortable with as they are just filling out a questionnaire on a regular basis. It certainly is more invasive. It feels more invasive. And it just feels on a different level than just filling out a questionnaire and saying about your diet or what you've been diagnosed with over the last period of time. And yet you will notice that many trials have a blood collection component to it. And why would that be? Well, really it's for two reasons. One is directly related to the study itself, and one is a broader issue as for the study being a resource for other things to come. So the first reason is that the blood specimens that can be obtained at baseline before anybody starts having their intervention where they get supplementation with vitamin D or placebo, or supplementation with fish oil or taking placebo, greatly enhances the interpretation of the results of the trial. And if we can think of so many ways where having that information before they ever got started taking the drug would be important. One relates back to what we talked about in the last session, which was compliance. Remember we said we would look at self-report, but it would be so nice to be able to validate it against actually what is in the bloodstream levels of vitamin D or fish oil in the participants. Well, we can actually do that with the blood specimens. We can assess pill-taking compliance in these samples. We can also see how you take a certain supplement of a certain level, but does everybody have the same levels in their blood? Does the milligrams or the international units in the pill translate to what your level is going to be in your blood? Well, we can actually find that out with the blood samples. So we can correlate what the people were taking in terms of their pills. We know that. We gave it to them. We can see whether they complied with it. And then we can look at blood levels and look at the variability in the levels of vitamin D or the omega-3 fatty acids with these medications. For those who are taking placebo, what can we do? Well, we do know that foods are being fortified. And so it would be very interesting to look at those who are just regular, eating out what is out there, what has been increasingly fortified, and we could look at the trends in their blood of background fortification. So that means we can look at the active agents and see how their levels are changing with the pill that they're taking. We can look at the placebo bloods and see how their levels are changing, not due to the pills now, but with the fortification of the food supply with vitamin D or omega-3 fatty acids. In addition, we can look at particular groups that are of most interest to us. And remember a couple sessions ago, I said one group we're really going to want to look at very carefully is African Americans. Because of the pigment in their skin, they have lower levels of vitamin D, but they have higher levels of developing cardiovascular disease. So I would particularly want to see when we give a vitamin D supplement or a fish oil supplement, how does that translate into plasma levels of these agents? And we can actually look at it in African Americans compared to other ethnic groups. That's something we can do with those blood specimens. Another group we're interested in is body mass index. For those who are over a body mass index of 30, for example, who would be categorized as obese, does that change in any way the metabolism of the vitamin D, the levels of vitamin D, the effects of vitamin D. That's something we'll be able to look at because we have these blood specimens. And we can also look at markers of possible side effects of the agents, for example, hypercalcemia. And we can have it reported by the participants whether they have been diagnosed with hypercalcemia, but we can actually measure it directly ourselves, which would allow us to be able to safeguard the safety of the participant group in a way that we couldn't do without the blood specimens. Now, how do we go about collecting a blood specimen? Especially remember that Vital is being conducted entirely by mail. So these participants are not coming into the clinic where we can draw the blood specimen for them. So what can we do? Well, we go ahead and mail a blood kit to the participants. For anybody who indicates on their questionnaire that they would be willing to provide a blood sample to us, we actually send them a blood kit. And that blood kit contains everything they need to have their blood sample drawn and mailed back to us back in our laboratory. So they can bring it to their healthcare provider, they can take it to a blood drawing laboratory of some kind, hand them the kit, every vial they need, the tourniquets, the needles, the Federal Express pack, the gel pack that'll keep it cold during the period of time, all that is provided. And it can get back to us within 24 hours. Now, if some people say, well, I maybe could do it, but it's going to be a little hard for me to get to my doctor or a little hard for me to go get to a lab. Is there anything you can do to help me? We can help them. There is a company called EMSI, Examination Management Services Incorporated, who have sites. They have more than 200 sites in 15,000 cities across the United States. The participant can actually go to their site and they will draw the blood for them. Or, if need be, they can go to their home and draw the blood for them. So we have many different ways to enhance compliance with the blood drawing because that's so important to us. And if people need assistance, that's something that we are able and willing to do. When the samples get back to our laboratory within 24 hours, then we take them, we aliquot them, put them into smaller little tubes. We put them into freezers. We'll put them into nitrogen freezers at a very low temperature, and we're going to store them for a long period of time. Because of that, we don't put every person's, all of their aliquots in the same freezer. We actually take the aliquots and we divide them over multiple freezers. So if something were to happen, and one of the freezers ever were to have a power outage and the samples thaw, we would never lose all of the samples of an individual. We would always have other samples in other freezers that we would be able to use, which would honor the contribution of someone who is giving us their blood sample. We're actually working towards getting 70% or greater of our participants to give us a blood sample at baseline prior to randomization. We also want to get a 2-year follow-up blood and even a 4-year follow-up blood if we can do so on 2,000 of the participants. And for those who do go to the clinic setting, to the Clinical and Translational Science Center that Joanne Manson told you about, the CTSC, then we're going to get baseline and follow-up bloods from those 1,000 participants also. Remember I said there was a second reason why we wanted bloods? One was for all of those reasons, all of those explanatory, exploratory analyses that we could do for our own study with the blood. But there's also a second reason, and that is to create a rich resource that can be used in the future to evaluate hypotheses that are as yet unknown to us. So at the end of the trial, when we're done in 5 years, we hopefully will have been able to answer our questions about vitamin D in fish oil in a high quality and definitive way. But in addition to that, what an amount of data we're going to have. We're going to have extensive demographic, lifestyle variables, medical history variables, and biomarker information on a large number of participants, 20,000, updated over a number of years, 5 years, with a substantial number of underrepresented minorities, hopefully 5,000 African Americans. And with these stored specimens, it is going to mean that in the future, an investigator, us or other investigators, can use these resources to evaluate future biomarkers or genetic analyses that in 2012 haven't even been imagined yet. And this is going to be particularly important because it's going to mean that in these very tough financial times in terms of doing research, we can use an existing study for more than just the original questions. We, of course, would need Institutional Review Board approval to extend beyond the original study and look at it. But with this approval, we would be able to use these blood specimens, use the data that we have collected to advance development of knowledge in many areas that hadn't even been thought about. And we can do it not just in randomized trial methodology, but in case cohort methodology and in nested case control methodology, methodologies that you will hear about in this course. So it is especially a wonderful way for young junior investigators who in this time would be hard-pressed to get enough money to be able to launch a cohort of this size on their own. They can take advantage of cohorts that already are available, collaborate with the investigators of these cohorts to graft on or add on ancillary studies, allowing them to answer questions in a very cost-effective way.